Okay, so that nothing is lost, and I'm sure will be an amazing discussion. Okay, we would love to hear the chief concern, and then we'll get going.
Yeah, so the chief complaint is 65 years old male with lower limb weakness and difficulty walking for 4 months.
You said lower body weakness and difficulty walking.
Lower lower limb weakness.
Lower limb weakness and difficulty walking for 4 months. Thank you. Okay, Valeria, what are you thinking here? Just hearing that first little bit.
Yes, thank you. Your presentations are always very clear, and I think for this we have a lot of information. First, that the patient is quite on the older age of the spectrum, and also the tempo, which is chronic, and the localization, which I think lower limb weakness is one of those localizations that's really helpful. I think we've been through it before, but just going through the corticospinal tract one more time, from the cortex all the way to the periphery. In the cortex, usually you are not going to get this pattern of weakness because both medial sides of the frontal lobes would have to be affected. And in that case, we think about the exception of the anatomical abnormality in the anterior cerebral artery or mass compressing bilaterally. However, which could be a possibility given that this is a chronic onset of disease. And then going lower through the corona radiata and then through the brainstem and then to the spinal cord. The coronary radiata, brainstem, all those localizations in the brain are a little less likely if it's only lower limb weakness. And then the spinal cord kind of takes the focus in this presentation. I think we're thinking about lower than the thoracic, lower in the lumbar region when this is affected. And when thinking, and then, well, you can go lower to the peripheral nerves or the roots first, then the peripheral nerves, and then the neuromuscular junction, and then the muscle itself. And it will be very helpful to kind of think about, if it was proximal, then distally, or if it was distally and proximally, to differentiate between myopathy and peripheral neuropathy. And then if there's sensorial component to this, to think also about neuropathy. But if not, I think I will focus on the spine lower. And also another thing that I always remind myself to think are the meninges. I believe I learned this from you, Aaron, about the meninges going all the way down to the spine. And so that something affecting the meninges can also present with lower limb weakness. I've seen it actually, but more rare, and also more rare if it's 4 months of presentation. So yeah, and on the tempo part of this chief concern, I will think about things that take a lot of time to present, such as like a mass growing on the spine that could be compressing bilaterally, and also chronic neuropathy could be something like, for example, diabetes that can also present with lower limb weakness, but I'm not sure we're going to see something so systemic in Neuro VMR.
Excellent. Give me 1 second here. I think there's a scribing difficulty, so I'm just going to make someone else co-host, and we have to remember, if we podcast this, to edit this part out so people aren't bored with our technical difficulties. There you go, Elena. Thank you. Okay, and if we're editing, whoever's editing someday, this is where you would pick back up. Okay, brilliant discussion, Valeria. Localization and time course. Just to recap a phenomenal discussion, that I have a few questions for you before we hear more about the case. So I love what you did. When we hear weakness, or when we hear any chief concern in neurology, we try to think anatomically and lay out kind of the whole map of where something could be. And a little different than other parts of medicine, where we're really thinking about how the physiology would explain the patient's symptoms and signs. Excuse me, here we're really thinking about the anatomy, right? And you did that beautifully, saying we could be anywhere from the brain to the muscle, and you trace the corticospinal tracts through the cortex, corona radiata, internal capsule, brainstem, spinal cord, nerve roots, nerves, neuromuscular junction, and muscle. And you gave us examples of how along this pathway we could have lesions. And you said a few things I just want to highlight. Since you started from the top, You also started with the least common, right, reason someone would have bilateral lower extremity weakness. So just to sort of highlight for folks, since you gave us this beautiful overview of all the possibilities, when you hear bilateral lower leg weakness, and you sort of said this, I just want to bring it out. What are the most likely localizations that you think of? You gave us the whole landscape, but just sort of probability-wise, what are the places you're focusing as a first pass when you're going to examine and then evaluate this patient with other testing?
I think for me, the spine. And I remember you thought this before, that we should think about the spine rather than the spinal cord only, because of the other structures that are in that localization.
Fantastic. I do say that often, and I'm glad to hear you saying it as well. Yeah, I think first pass, if this is truly isolated bilateral lower extremity weakness or other symptoms, and there's really nothing in the arms and nothing above the neck, then most likely would really be spine. And I've tried to train myself to say spine instead of spinal cord, because within the spine, there's also the cauda equina, the nerve roots, lumbosacral nerve roots. Spiller said there's also the meninges, there's the vertebrae, other structures there that could be involving the spinal cord itself. So not everything within the spinal canal that's pathology of the spinal cord. I agree with you, Valeria. And then probably the most gourmet, most rare would be, as you said, a midline parasagittal process affecting those leg areas of the homunculus that are sort of on the medial surface of the homunculus. So a parasagittal meningioma or a bilateral anterior cerebral artery strokes could sometimes fool you. You would probably have looked at the spine first, trying to work this patient up if the exam also suggests that. But then if you don't find anything, you might go back to the brain. And then you mentioned muscle, neuromuscular junction, nerve. Are those possible here, or what kind of information are you going to be looking for in the history to try to distinguish between whether your initial hypothesis and sort of Bayesian reasoning that probably this is something spine, most likely, though we're staying open, we have very little information, versus maybe this is something in the periphery, peripheral nerve, neuromuscular junction, muscle. What kind of questions are you going to be asking on the history before we get to the exam to try to tease apart this is in a spine, spinal cord or cauda equina, or this is maybe in the peripheral nerve, neuromuscular junction muscle?
I think, well, for the peripheral nerve part, I will think about if there's also a sensorial component to it, because it has the presence with that. The neuromuscular junction, I will think if it's episodic or not, if there's fatigability, like it presents more on at the end of the day. Then with muscle, if it's proximally predominant, and also if there's, I mean, for example, the exam is going to be key, of course, if the reflexes are, upwards or not, and if there's a sensory level that could clue us to the spine.
Yes, I, like you, am eager to hear that exam. But there's some things we can get from this. One would be sensory, right, which would either keep us in the cord, cauda equina, or in the peripheral nerves, but would certainly exclude neuromuscular junction and muscle, right, if there was a sensory component. There's probably one other big piece here that's, for me, a big branch point in the history, or something that would be important. It's not always going to tell you the answer, but between cord, cauda equina versus peripheral, a question we always ask about a particular function.
Is it autonomic dysfunction?
Yeah, specifically what organs?
Like urinary incontinence?
Yeah, exactly. I was a little bit guess what I'm thinking, but you guessed what I was thinking. Yeah. And if you have bowel and bladder involvement, that really puts us more towards the cord or cauda equina, and you really don't see that with peripheral neuropathy. You can get autonomic dysfunction with peripheral neuropathy that affects autonomic peripheral nerves, but usually more orthostasis, things like that. And then neuromuscular junction, I've never seen a case of Lambert-Eaton. I don't think I've even met anyone who's seen a case of Lambert-Eaton. They get some autonomic dysfunction. But you're right, neuromuscular junction disease, myasthenia, which would be the more common neuromuscular junction disease we see in practice, almost always affects that eyes proximal and is fatigable, as you said, but it is proximal. And that would be proximal pattern you'd see in muscle as well. So we're interested in hearing from the patient, what do you mean by weak, right? Maybe they mean numb, maybe they mean clumsy. We're interested in hearing about bowel and bladder. Is there any sensory problem? Are the arms involved? Of course, maybe they're subtly involved. We'll find that on the exam, and we don't know yet. Is there anything above the neck? So even from the history, we're starting to localize. We'll have a hypothesis. Then we go to the exam, as Valeria said. We really want to know what the reflexes are. This has been going on from some time. we'll either have upper motor neuron signs or we won't, and that will be another branch point for us. And then the time course, you said months is sort of chronic. I'd say 3 to 4 is a little more subacute. That's kind of ticking along a little more than years, for example. So as you mentioned, in that subacute bucket, we might think about if we're, again, the localization will be important here. If we are up in the brain and it's going slowly and it's parasagittal, we'd be thinking maybe of a parasagittal meningioma. If we're in the spine, maybe we could be thinking about a slowly growing mass, which could be tumor or infection. And you mentioned it could be a process anywhere within the spine, right? It could be something in the cord itself. Primary malignancy or neoplasm of the cord is very rare, but metastases to the cord are possible. Could be a neoplasm or metastases to the bones of the spine, or to the meninges. And then, depending on where this patient is, tuberculosis of the spine, of the leptomeninges, arachnoiditis, rarely tuberculoma in the cord. Other possibilities there. So sort of neoplasm, slow infection, if we're kind of thinking of something structural. And then if this turns out to sound more like muscle, neuromuscular junction, this kind of, or neuropathy, this kind of subacute makes us think, and that localization may be something a little more immune mediated. Just some initial thoughts. We'll have a lot to learn depending on the context here and a little more of the history. Okay. Thank you for that rich chief concern and great discussion, Valeria. I had very little to add, just sort of highlighting some of the fantastic things you said. Okay, can we hear a little more of the history, please?
Yeah, sure. Such a great discussion as always, Aaron and Ellie. So history of present illness. It's a 65-year-old gentleman who was previously well until 4 months ago when he began noticing difficulty walking abruptly one day. He said he felt like he was walking like a drunk all of a sudden. He was not experiencing any headache, vertigo, or slurred speech. And then things get slowly worsened since the time with his gait. He is now needing to be pushed in a wheelchair for longer distances. He is not experiencing any significant pain or sensory symptoms, except for maybe a little tingling in his toes and fingers. He has lost 24 pounds over this period, and he has experienced severe refractory constipation, as well as likely early satiety. He has no urinary difficulties, cramp, dysphagia, orthopnea, fasciculations, diplopia, or other vision changes. He was even hunting and hauled large deer out of the woods just a few months prior to this. And despite the absence of any pain or significant symptoms, he underwent multiple lumbar spine injections, spine pain management, and radiofrequency ablation. So that's all for history of present illness.
Okay. What are you thinking, Valeria? We have a little more information here.
Yeah, wow, this is really rich history. Thank you, eh? Well, yeah, okay, so there are a lot of things here that kind of make me worry that this could be a malignant process going on. First, the age of the patient, of course. Then I wasn't really expecting the abrupt onset of the weakness and then kind of like the progressive worsening of it. I'm wondering what, I mean, I would like to know a little bit more about that because it's a little odd for me that it took this long for the patient to seek neurological care. But I mean, I guess he was treating it with pain management. Then, well, so, and then also there's weight loss, which is another thing that makes me worried in this age group because of the gender of the patient. I will be worried about prostate cancer, for example, and metastasis to the spine. The fact that there's also constipation, that's the autonomic component that I think we were looking for. Could this maybe like a Cauda-Equina type of syndrome, slowly progressing? And then, well, the early satiety as well could be a clue for malignancy. So I think that's kind of where my mind is right now. I'm a little confused because of the sudden onset of walking like a drunk. I think, I'm not very good with assessment of gaits But I think with walking like a drunk, I often think of like a more of like a like problems with proprioception rather than weakness itself. So yeah, but I think I will still be in the spine for sure. And on the exam, well, it's gonna be key to see if there's this true weakness, autonomic component, the reflexes, everything. And I also like to know if the patient has any risk factors for malignancy, if he has done any like prostate cancer screenings or not. So yeah, that's kind of where I am at.
Yeah, fantastic discussion. Yeah, there's a lot of information, new information, interesting information here. You said you're still very confident you're in the spine. Can you tell us a little bit why that is?
Well, I think the fact that there's not other limbs affected, also that the autonomy component, I think, makes me think of the spine. And yeah, I think that mostly. And also another question that I'm wondering, you mentioned that there were no pain or sensory symptoms, but he still received lumbar spine injections for pain management. So that's kind of, I'm thinking, would there be pain or not? Because I think that will change a little bit my thought process.
Yeah. So what my thinking was when I first heard walking like a drunk, of course, this is a limitation of our exercise here. In real life, you would have seen the patient walk in before you even take the history, and that would have guided already some thoughts and maybe some questions. But that sort of makes me think of ataxia. You mentioned a proprioceptive problem, or maybe a cerebellar problem. Although if someone has proximal weakness and they have kind of a Trendelenburg waddling gait, maybe they would say it looks or feels they're walking like they're drunk. But people with sort of subacute spinal cord compression or processes, most common thing we see in everyday practice would be just cervical spondylosis causing a cervical myelopathy, and other lesser common conditions as well. It feels a little atypical to me just in my experience, though maybe we'll learn in this case, to have this profound constipation with nothing going on in the bladder. I don't know why. It just seems like patients are more likely to have, with spinal cord or cauda equina, more prominent bladder symptoms in my experience, but I'm not 100% sure of that. Then the early satiety, again, not something we really think about that much in neurologic disease or economic component to a neuropathy. Most common cause would be diabetes. So I'm really curious on the exam, and you and I went with an initial discussion of the weakness component. We could have equally begun with a discussion of the gait component, and then we might have said this could be weakness, pain, sensation, coordination, vision, cognition, higher order control of gait, which could be affected, say, in normal pressure hydrocephalus causing gait apraxia, or Parkinson's causing a Parkinsonian gait. So I think this is one where, the limits of the history and not seeing the patient with our own eyes, where the exam is going to be particularly helpful, because I think we activated the weakness localization schema, and it may be that the patient is weak and we come back to that. It may be that the patient is not weak at all and they're ataxic, or having a large difficulties or major difficulties with proprioception. What would put us away from cerebellar? Well, if it's severe enough that the patient's in the wheelchair, maybe you'd think about some slurred speech, which A specifically told us there was no slurred speech. But if you had a midline cerebellar lesion, could just affect trunk and gait maybe. So I think the cerebellum kind of feels more in play to me than maybe we initial thought from the chief concern. But I wouldn't know how to put cerebellum and kind of autonomic dysfunction together, and particularly early satiety and constipation, unless there's some neoplastic process going on in the abdomen with a paraneoplastic cerebellar degeneration. Because I agree with the subacute nature of the weight loss, malignancy keeps surfacing. And then the question is, how is the malignancy causing the neurology? Is there a lesion somewhere, primary or metastatic, or is there a paraneoplastic process here? And what is that paraneoplastic process? I said earlier, I've never seen a case of Lambert-Eaton syndrome or met anyone that has. Maybe we're about to meet A who has seen a case, and this patient has some proximal weakness from neuromuscular junction dysfunction and has some autonomic difficulties, which do go along with that disease. But as I said, I haven't even seen a case to know if, the core of how they typically present or the ways they can present strangely. So I think for me, I feel a little bit, this is the kind of history without seeing the patient. I would say I really need to, let's do an exam, and then maybe I'll have more questions about the history when I see where we are, because I'm a little bit uncertain at this point where the problem is until we see if there's weakness, sensation, problem, ataxia, or all of the above.
Yeah, I just wanted to add, Aaron, that maybe something that really threw me off was that weight loss and also the constipation. And made me think like the egg or the chicken, maybe because we're thinking often of like cerebellar degeneration through to toxicity or like mineral or vitamin deficiency. Could it be like maybe the weight loss and the constipation was before, and that caused like a deficiency, and now they're presenting with ataxia, which I think you made a really great point that we don't really not certain that it's only on the lower limbs, because walking like a drunk, often all your limbs are affected.
Yeah, great point, Valer. What if we reframe this, and the primary thing going on here is in the GI tract, and we have a vitamin deficiency? What neurologic conditions were you thinking of that could be related to the constipation, early satiety, maybe all that, as you said, is medical GI primary problem, causes vitamin deficiency, and then what neurologic complications of vitamin deficiency would explain the gait problem in that case? What were you thinking?
Well, yeah. I think vitamin B12 is often the one that affects a lot of places. I think the cerebellum, the spine, and the nerves can be affected by vitamin B12, and also even the brain, because I've seen like neurobehavioral manifestations of vitamin B12 deficiency. But I often think the nerves and the spine more than anything else that are affected by vitamin deficiencies.
Yeah, any vitamin deficiencies you could think of that would cause ataxia?
Like B1, thiamine deficiency.
Yeah, excellent. Yeah, very good. So yeah, B12 deficiency can cause neuropathy. B12 deficiency can cause subacute combined degeneration, which is dorsal column and corticospinal tract, posterolateral spinal cord syndrome. It can cause both together, myeloneuropathy, where you get mixed upper and lower motor neuron signs. And it can cause neurobehavioral or cognitive changes. B12 is in the workup for almost every, neurologic syndrome, and it's often can be found to be low for various reasons. Metformin can reduce the absorption of B12, for example. It's not always clear whether it explains the neurology. And then vitamin B1, we always learn this Wernicke's triad, right, of eye movement abnormalities, altered mental status, and ataxia, but the literature tells us that less than 30% of patients have the full triad, which makes the triad itself relatively useless. That someone could be just confused and have Wernicke's encephalopathy or just ataxic. So that's another possibility here. And then you'll see on lists of the cause of cerebellar ataxia, vitamin E deficiency. I'm not sure how you even get vitamin E deficiency, and I think you need some other genetic hit where you have some vitamin E processing issue to get a vitamin E associated cerebellar ataxia. The other GI cerebellum connection is there is reported a gluten associated ataxia where patients have celiac physiology and develop an ataxia associated with the antibodies that are associated with celiac that improves with a gluten-free diet, and they don't always have the systemic manifestations of celiac. So when we're really digging, we think it's a cerebellar problem. We have, imaged the cerebellum. We can't find anything. Then we start wondering about these rare things. Part of that expanded kind of imaging negative cerebellar process workup, if you don't find a cancer and presume paraneoplastic etiology, would be things like celiac antibodies. Okay, but I really don't know which schema which map we are navigating here in our diagnostic ship here, Valeria, until I think we see the exam, and then we can, I think, make some leaps here. Okay, anything to know about for the past medical history meds? I remember you said the patient was healthy, very active. You did mention they were hunting deer, so I had a brief moment of putting on my neuroinfectious disease hat and wondering what can you get from eating deer. I think there is someone can fact check. I think there is a prion disease in in deer, if I'm not mistaken, but I don't know if it would look like this. I could be wrong about that. Okay, anyway, I wasn't sure what to do with that, but just since we like to try to make a connection to every little piece of information, acknowledging that in real life, often the not every piece of information counts, like on step one. Okay, anything to know about in that bottom corner aside from deer hunting?
No, I was just adding that to make sure he is a very strong and very well person before. So
Okay.
yeah.
All right, then Valeria and I are very interested to hear this exam and know if we are talking about the corticospinal tracts, if we're talking about the muscles, neuromuscular junction, or the cerebellum. We really are not sure based on what we know so far.
Okay, great. So past medical history and surgical history are not quite relevant. On medications, he was on meloxicam, maybe from pain management prescription, but no known drug allergies. And on social history, he smokes half a pack of cigarettes for 30 years. He doesn't drink or use recreational drugs. And family history, it's not relevant. So you just want to continue for physical examination? Okay.
Yes, please.
So on physical examinations, vitals are normal, blood pressure is 125/85, pulse rate is 100, respiratory rate is 18, and SpO2 is 96%. The general appearance is he is quite chaotic and appears chronically ill. On head and neck examinations, there is no scalar iterus or injection, and on cardiovascular and respiratory examinations are all normal, and abdomen is soft and no palpable mass. On musculoskeletal examination, normal joint movement, no joint effusion, and on skin, there was no rash. So on neurological examination, mental status, the patient is alert with fluent speech and adequate attention. On cranial nerve examinations, there is no ptosis, but pupils are entirely unreactive at 5 millimeter. Eye movements show full version without nystagmus, no facial numbness or asymmetry or hearing loss, normal tongue movement without atrophy or fasciculations. On motor examination, overall appearance is chaotic but no fasciculations. Tone are all normal on all limbs. Power is reduced on both shoulder abduction, elbow flexion, and extension, and it's 4/5, but normal on both wrist flexion and extension. And reduced on both hip flexion and extension is 4- out of 5, but normal on both knee flexion, extension, ankle dorsiflexion, and plantar flexion. So it's kind of like both proximal muscle weakness. And reflexes are all absent on all reflexes, bicep, tricep, supinator, knee, and ankle jerks. But plantar is equivocal. And on sensory examination, there is no sensory loss or numbness, normal pain temperature, vibration, and proprioception. On cerebellar examination, there is no ataxia, dysmetria, or dysdiadochokinesia. And on gait, it's kind of like waddling gait due to proximal muscle weakness, not due to cerebellar ataxia.
Okay, hey, you cut out briefly during the motor exam. Oh, it looks like it's still got all transcribed. Maybe it was on my end, sorry. So just to make sure, the weakness is in shoulder abduction, elbow flexion, extension, hip flexion, and extension, but distally the
Yes.
strength is normal.
Yes.
Yes. Okay, it was weakness, Valeria. All right, so we were on the right track after all. So what are you thinking now that you've heard this exam?
Yes, well, things that come to mind first are is a general aspect of the patient. He's cachectic, chronically ill, which it's a little odd for the subacute onset of disease. Like it feels like it's rapidly progressing for him to be so consumed by the disease. And then the fact that it's not only weakness on the lower limbs, it's also on the upper limbs, proximally predominant, which makes me think, okay, it's not so like the spine is not the only possibility here. And also the fact that the reflexes are absent makes me think, okay, could this be more a peripheral process rather than a central nervous system process? The proximal predominance of weakness, I really don't know what to do with that because it makes me think first of muscular disease, but the absent reflexes, I think, point more to a neuropathy type of picture rather than a muscle disease. So I will put my bet on a neuropathy here. And then another thing that threw me off completely was a reactive pupil that's my Adriatic, it seems. Um, uh, I don't really know what to do with that because could it be like a it's both pupils are unreactive and Adriatic. I don't know. I really don't know. But right
Oh,
now I'm thinking, okay, more away from the spine and more to
I
the
think we
peripheral.
lost you, Valeria, or is it
Oh,
me?
um, can you hear me? Oh, I think it might be Aaron then.
Yes, very pupils or full pupils are unreactive.
Okay. Thank you, A. I think we should wait for Aaron too.
Yeah.
We're a little stuck. Oh no. Okay, we can wait for Aaron then. Hey, I just want to say that I love your cases. They're always so well presented.
Yeah, well, actually, it's a gift for Aaron. You will see. It's a surprise gift.
Let's wait for him. Oh, Kashmir, are you on a neuro rotation? That's so cool. Are you enjoying it? Yeah, totally. Neurophobia is real for sure. Maybe we can go over some of the comments on the chat. I see. Mm-mm-mm. Oh, Elena, I was just about to ask the same question to you on the chat. Or well, to everyone, what do you make of the pupils? Because for me, okay, like pupil reactive, that's parasympathetic system. So um like yeah, the parasympathetic system will be compromised. So like a diffuse autonomic involvement, maybe like that the constipation plus the pupil. Um, oh, Aaron is back, but I
I'm
really
back.
don't know.
My
Oh,
internet went out. I last heard you, Valeria, saying you thought this was in the peripheral nerves, and then you were stumped by the pupils, and then I lost you. I'm sorry, my internet went out and came back. What did I miss?
no, you're good. We were just talking about the pupils. I was, saying that I really don't know what to make of that because I think unreactive pupils make me think that the parasympathetic system is not working very well. Um, and could it be like another autonomic dysfunction plus the constipation that we saw before? But then there's nothing else that points us to a broad autonomic dysfunction. So this seems very pointed. Um, but I mean, the parasympathetic fibers are part of the third nerve. So could it be part of like a diffuse polyneuropathy that's affecting also some part of the cranial nerves? I don't know. But yeah, I am thinking more of peripheral nerves right now, but I don't know what you think.
Okay, great thoughts. I am not thinking of the peripheral nerves. What's got you what got you to the peripheral nerves here so we can see where we're diverging?
I think mostly the absent reflexes.
The absent reflexes. Yeah. So good point. When the reflexes are absent, normally we would think peripheral, meaning root or nerve. As you said, you should see preserved reflexes in muscle disease unless the muscle is too weak to generate the reflex. So someone who has very severe myopathy, for example, who's so weak they can't even move the muscles involved in the reflex, then you can lose the reflex. But generally, the reflex should still be preserved in muscle disease. But what makes you, if we forget about the reflexes, sometimes useful in clinical reasoning, we try to put everything together, and we will be able to do that, I think, in this case. But if the reflexes have put you on peripheral nerve, Valeria, what other things here make you feel like that doesn't sound like a peripheral neuropathy?
The proximal predominance of the
Yeah. What does that make you think more of?
myopathy.
Myopathy or
Like neuromuscular junction?
neuromuscular junction? Yeah. Proximal weakness, if we didn't see the reflexes, we were going down, we heard the motor exam before we checked the reflexes, we might have said, oh, this is starting to feel more like muscle or neuromuscular junction disease. And then we got the reflexes and said, well, wait, hold on, is there a neuropathy? But also there's no sensation affected here. You can get a pure motor neuropathy, but less common. And then that proximal weakness doesn't really fit a neuropathy pattern with no distal weakness. A non-limb dependent neuropathy could cause distal and proximal together, but probably not just proximal. And then we have these pupils. After moving things a little bit in that direction, Valeria, any other thoughts? And then I can tell you what I'm thinking. So if I don't think this is neuropathy, we'll still have to explain those reflexes. But proximal weakness, you're thinking muscle neuromuscular junction, there's a pupil problem, there's no reflexes. Anything come to mind? Oh, and okay, if not, yeah.
Now I'm just curious how to kind of to make fit together the pupils with the proximal weakness. I'm curious about what you think.
Yeah. Yeah. Okay. So proximal weakness, I would have said muscle most commonly, and then second, neuromuscular junction, just in terms of common things being common. And then the reflexes being absent and the pupils, we have to put that back in. So I was making the joke earlier, but maybe it was a joke that was in tune with this case, because this sounds like, at least the descriptions I've read of Lambert-Eaton syndrome. The patient has proximal weakness. The reflexes are absent, and I would love to hopefully see this one day in real life, because in Lambert-Eaton syndrome, I don't know if you tested this and just didn't tell us not to give it away, but in Lambert-Eaton syndrome, when you have the patient exercise, the reflexes can actually come back. So myasthenia gravis is a postsynaptic neuromuscular junction disorder. Lambert-Eaton is a presynaptic neuromuscular junction disorder. So in postsynaptic disorders, of which, as far as I know, myasthenia is the only one, the patient fatigues because as all that acetylcholine rushes across the synapse, essentially you saturate the limited receptor capacity because the antibodies are attacking the receptor, and you fatigue. But with the presynaptic issue in Lambert-Eaton, botulism is another example of presynaptic. In Lambert-Eaton, there are antibodies against the voltage-gated calcium channel that is activated at the synapse, that when the calcium rushes in, at least the synaptic vesicle fusion and acetylcholine release into the synapse. And for some reason, exercise, I don't know, or I don't remember the physiology, exercise somehow increases, I guess, the amount of calcium coming in or the amount of acetylcholine that's released, and you get this sort of second wind phenomenon. You can see that if the patient has no reflexes or diminished reflexes, then you have them kind of 20 times or 50 times exercise the muscle and then check the reflex again, it can come back. Very interesting sign I've never seen in real life, but read about it and sounds very interesting. And then autonomic dysfunction is common in Lambert-Eaton syndrome, as we mentioned, and often affects the pupils. So yeah, it'd be sort of weird, as you said, Valeria, to have a process affecting the muscles and both third nerves, or the peripheral nerves and both third nerves. So probably if you see bilateral pupillary dilatation, either there's eye drops or there's some maybe systemic process here. So this sounds to me like Lambert-Eaton syndrome, and sounds like what I've read about it. I've never seen a case. So already admire A's neurologic experience and her repertoire of cases, but wow, if she's seen one of these, I am so excited to hear more about this case. And if we think this is Lambert-Eaton, Valeria, from the beginning, you've been concerned about cancer, first from the time course, then from the weight loss, then from the cachexia. How would cancer be related to Lambert-Eaton syndrome?
I believe it's related to squamous cancer, lung cancer, or yeah. So I will think like to screen with a chest X-ray and see if there's anything there. And I didn't know Lambert-Eaton presented with papillary components. So thank you. That's another thing for my schema.
That's my understanding. Yeah, they often have unreactive pupils. Botulism as well, right? Another presynaptic disorder. And I don't know why the pupils in specific are affected, maybe just sort of sensitive to autonomic dysfunction. I don't know. Maybe someone who knows can tell us, or maybe A is going to teach us. Yeah. So this sounds like Lambert-Eaton. We have the smoking history, the cachexia. I think the most common is a small cell lung cancer. Someone can fact check me. I think can be associated with thymus also. That's bubbling up, but I could be wrong. Obviously, myasthenia is associated with thymus, but like any paraneoplastic syndrome, it can be associated with any cancer, but common things being common, probably small cell lung cancer in this case with the smoking history and the cachexia. You can also get Lambert-Eaton syndrome with no cancer, just as a autoimmune antibody syndrome with this voltage-gated calcium channel antibody. And of course, you would screen in great detail for cancer. And if you don't find cancer with a classic paraneoplastic syndrome, like cerebellar degeneration with the associated antibody, like Lambert-Eaton with the associated antibody, I think the guidelines or guidance at least is to keep screening for cancer every few months, because remember, the reason the paraneoplastic syndromes arise is because the immune system is doing what it's supposed to do, attack the cancer, and the cancer may be expressing a certain receptor that the immune system is going after, and that creates a response against that receptor when it's in its appropriate location as well. For example, the NMDA associated anti-NMDA receptor associated encephalitis with teratoma, I believe, though someone can fact check me, that teratomas are actually expressing the NMDA receptor. You know, these are tumors that express hair and teeth and neuronal elements. And so the body is appropriately attacking the cancer and then ends up attacking the body by accident. I mention that because the immune system is revved up to cause this and to go after the cancers, such that in some cases, the cancer is too small to be detected at presentation because the immune system is doing a really good job at keeping the cancer in check. So these are the kind of situations where you might not see anything on a CT, but see something on a PET scan. 2 years you're supposed to do before you say this was just sporadic Lambert-Eaton, a rare instance of an already rare disease. But you would want to follow this patient very closely for cancer. And in this context, with the weight loss and cachexia, I think we can be pretty sure there's cancer here, unless all this autonomic GI stuff, as you mentioned, Blair, has just caused him to stop eating. Maybe he's fortunate and only has Lambert-Eaton and doesn't have an underlying cancer. That's a possibility. So I agree. The next test probably would be looking for lung cancer. If you weren't sure of your localization here, or for academic learning purposes, because you say, I've finally seen Lambert-Eaton the only time in my entire life. Do you know, Valeria, what you would find on EMG in these patients? Okay, if you don't, it's a little bit gourmet.
I don't remember. I'd love to learn.
Yeah. A, do you want to teach us? Well, for I don't know if I'm being very presumptuous that we already have the diagnosis here. But
can you imagine, like A's like, no, like throws us after this.
It's spinal TB. Yeah, tricked you. He just has a pupillary injury bilaterally and a base and an underlying diabetic neuropathy. No. Okay. A, if we're on the right track here, or is there more information you'd like to tell us, or should we start talking about how you went after diagnosing this rare condition?
Yeah, I can talk about more nerve condition study and EMG.
Yeah. Yeah, please. Yeah.
So this is a case from neuromuscular clinic that I have been shadowing, and not from Burma. I was presenting all the previous cases are just from Burma. And also this is a case from just here from Missouri and the neuromuscular clinic. So we just did nerve connection study and EMG right away. So the results came out like the right tibia motor nerve connection study shows no response, and the left tibia motor nerve connection study shows a tiny compound muscle action potential amplitude, and the right and left peroneal motor nerve connection study show no response, and the left median and radial sensory nerve connection studies are normal, and the left and right suprasensory nerve connection studies are normal. And the left median motor nerve connection studies from the epidural pollicis brevis show a tiny distal compound muscle action potential amplitude that increments by a factor of 10 following brief maximal exercise. And then neither EMG was performed in the following two muscles of the left upper extremity, deltoid and biceps, and they show myopathic features with mildly early recruitments of generally small motor units without fibrillation potentials. And then neither EMG performed on two muscles of the left lower extremity, vastus medialis and tibialis anterior, show poor activation and motor unit morphology was not well characterized. The tibialis anterior show early recruitment of generally small motor unit potentials without fibrillation potentials.
Okay, there's a lot of detail there, and as much as you, Valeria, and I love neurology, many of our colleagues also love neurology, but to have some take home from that EMG for everyone, what's the classic finding that you did say amongst these findings, for Lambert-Eaton syndrome or for any presynaptic neuromuscular junction disorder? What's the main finding here to highlight? Hey, what's the main finding here to highlight for Lambert-Eaton syndrome amongst all those findings?
All right. So the left motor nerve connection study shows a tiny distal compound muscle action potential amplitude that increments by a factor of 10 following brief maximal exercise. And I can also show you the
cool.
waveform.
Wow, cool.
Yes, can I share the screen?
Please. Please do. Yeah, so myasthenia, you might remember as exercise, you fatigue. And so if you do repetitive stimulation and record the motor amplitude, then you see that there's this sort of decrement. And with the presynaptic disorders, it's the opposite with repetitive stimulation, that somehow you electrophysiologically either bypass or this sort of the electrophysiologic lesion, so to speak. I don't remember the exact physiology. And so the more you stimulate, you actually get an increment of the signal, just as you get the post-exercise facilitation. Do you have a picture, of that beautiful kind of overlapping waveforms, maybe on a different page of this? Those are just...
Yes. Can you all see my screen?
We can see, yeah.
Oh, okay. So this is the baseline median motor nerve connection study, and it has just very low amplitude of compound muscle action potentials. And this is the post-exercise compound muscle action potential potentiation.
And did you do repetitive? Oh, I'm sorry. Go ahead. You're still teaching us. Go ahead.
Oh yeah, and the other motor nerve connection studies are all absent. There is no response there. And also right here, there was no response on left tibia and right tibia motor. And the sensory nerve connection studies are all normal. They show the compound muscle action potential amplitude right here. Yeah, so.
By any chance, did you do the repetitive stimulation? Do you have a picture of that with the increment to show people? No worries if not. It might be on a...
yeah, this is he didn't do the repetitive nerve stimulation. He just do pre and post exercise. Potentiation.
Got it.
On nerve connection.
Okay, so we have electrophysiologic correlation with our clinical exam. And did you check on exam if with exercise the patient got stronger or their reflexes came back by any chance?
Yeah, we didn't have a chance to do that.
No.
We just do the physical examination first, and it was just absent even with reinforcement. So
I see. Okay. And then at this point, you were pretty certain of Lambert-Eaton syndrome. And what would you do next here, Valeria,
yeah.
if this is...
Well, to look for the malignancy, I think with tomography.
Yes, yeah. I think first step would be a CT of the chest, abdomen, pelvis, or if we were in a resource limited setting, a chest X-ray or a CT of the chest to start if we couldn't get a view of the full body. Yeah. And was there a lung cancer here, A?
Yes, we just referred the patient to WashU, and then he did chest X-rays. He did a CT scan of the chest, and then biopsy. It comes out like small cell lung cancer, and also that voltage-gated calcium channel blockers, voltage-gated calcium channels antibodies are all positive, and he just got treatment. But now, for the last follow-up, he was even regaining all of his reflexes and improvement in some muscle power.
Wow. And was that with treatment of the cancer alone, or did he also get some immunomodulatory treatment for the paraneoplastic syndrome?
Oh, I'm so sorry. I didn't know anything about that
No.
specific treatment.
Okay. Yeah, don't be sorry. Yeah, I'm actually, as I've never seen a case of this. Of course, you're going to treat the underlying cancer, but if the patient's very severely affected, I don't know the guidelines for Lambert-Eaton specifically, but often you'll consider plasma exchange to try to remove the circulating antibodies. I actually don't know the protocol here. If the patient, depending on how weak they are, how severely affected they are, if you could try treating the cancer first, or whether you do cancer therapy plus steroids or cancer therapy plus a round of plasma exchange, and then C, I actually don't know for Lambert-Eaton. Okay, what a case here. We have exactly 5 minutes before another CP Solver session begins. Valeria, I'd love to hear your reflections on our journey here briefly. I can say some of mine, and then we'll hear some teaching points if we have time, and then we'll wrap up.
No, this was a treat. Thank you so much. Your cases are always amazing. And I mean, you told me you had a gift for Aaron, and this was totally a gift for both of us. So thank you so much. And I just learned so much from the approach to weakness, and also updated my schema for Lambert-Eaton to include the pupil compromise. So thank you.
Yeah, fantastic. Yeah, this was an interesting because we heard weakness and difficulty walking. We both kind of latched on to weakness. And then when we sort of laid out the whole landscape, but then when we heard the history, we thought, oh, could this actually be ataxia? There's nothing else going for cerebellum. There's autonomic stuff, but it doesn't sound spinal. There's weight loss, which sounds like malignancy. And then it was really here the exam where we said, well, first there's pupils, and that this is proximal weakness. I think one other little teaching point here is that the reflexes, we always, when they're absent, we always think peripheral, meaning particularly root or nerve, but very rarely the reason that the reflexes can be out can be a presynaptic neuromuscular junction disorder like Lambert-Eaton. Very rarely. Like I said, I've never seen this. I visited the Mayo Clinic at one point where I think Lambert and or Eaton practiced, and I was asking around, has anyone seen a case here? And at least the residents there who see everything at the Mayo Clinic in Rochester, the ones I talked to, said they had not yet seen a case. So amazing, A, that you have seen a case of something many neurologists have never seen or may never see. So thanks for bringing us this case and teaching us about this condition, which causes, unlike myasthenia, our other and much more common neuromuscular junction disorder. With myasthenia, we think of the eyes being involved, with diplopia, ptosis, no pupil obviously there, and maybe some proximal weakness as the disease progresses. This condition presents sort of looking like a myopathy with proximal weakness that's not fatigable and may even get better with exercise, but with absent reflexes and with dysautonomia, particularly pupils. And then we heard some of the GI dysautonomia here. So really phenomenal case, A. I'm glad you thought this was a gift for me. You can see how excited I am to hear about a real case from a person who's seen one in real life, and to know that they can get better, which is not always true of paraneoplastic syndromes. So great and really brilliant discussion, Valeria. Okay, in the 2 minutes that remain, whoever is scribing these fantastic teaching points, do you want to tell us 1 or 2 take-home points from scribing for this case and the teaching points you've extracted?
Well, yeah, you all pretty much summarized the entire case. And this was such a cool case with so many teachings here. I just want to mention some of the ones that wasn't mentioned in the last part. First, the vitamin deficiencies that can cause different presentations of ataxia, like B12, B1, B4, and vitamin E. And at the end, how a cancer can present with this autoimmune phenomena as a paraneoplastic, which was very interesting for me. The example of cancers expressing NMDA receptors on themselves, which lead to immune system reacting to that and leading to an autoimmune encephalopathy. But yep, amazing case. Thank you so much for the great discussion and great teaching.
Oh, thank you. Yeah, and great point. Yeah, it's worth knowing that some of these neurologic paraneoplastic syndromes, I don't know for other non-neurologic paraneoplastic syndromes, I presume it's correct, can be the presenting feature. So not a patient with cancer, you already know about the cancer and they develop a paraneoplastic syndrome. That can happen. But many times in neurology, we see the paraneoplastic syndrome, paraneoplastic cerebellar degeneration, for example, and realize this is a subacute severe cerebellar syndrome with no nothing on imaging, so there's no mass or no obvious reason for it, then as neurologists we think go looking for cancer, testicular, ovarian, breast, or lung. So sometimes, yes, the paraneoplastic neurology leads us to find the cancer when the patient has no systemic symptoms from it. Fantastic. Well, thank you everyone for the discussion. We're ending right on time. Apologies, I lost my internet there, but glad I found my way back to finish the discussion of this extraordinary case. We'll do, I think, 2 or 3 more of these in October and hope to see you all there on Tuesday mornings, not next week, but subsequent weeks. Thank you so much, everyone. Have a wonderful day.
Thank you.